Welcome to the Sniff Spotlight Series. I'm your host, Yitz Rubin, and this is sponsored by Renewal Rehab, the best therapy provider for sniffs nationwide. The Person of the Year award goes to the many healthcare heroes that have been sacrificing day in and day out to help your loved ones recover and come home to you during the thick of this global pandemic. Words cannot describe the gratitude that you so duly deserve. You guys are heroes, and thank you for all that you've done. Hi, this is Yitz Rubin. I'm introducing Glen Rundell and Cheryl Slavinsky. Glen is the founder and CEO of National Physiatry, and Cheryl is the VP. Glen has been providing physiatrists to skilled nursing facilities and other post-acute rehab settings for more than a decade. Welcome, Glen and Cheryl.
Good morning. Thanks for having us.
So, Glen, can you define physiatry and its role in a hospital versus a sniff setting?
Yeah, sure. Thanks, first of all, for having us. We really appreciate it. It's exciting times for rehab, and so we look forward to this connection. There's not a lot of difference between a hospital setting and a sniff setting or even an outpatient setting. It's really a degree of acuity. So if you have an episode, it could be cardiovascular, it could be any sort of episode. You go into the hospital for a procedure. You may spend a few days in a higher level of acuity care situation. There's a scenario there, then discharged to short-term rehab, which is a couple of weeks of really intense therapy through that period of time, and finally, possibly either discharged home or to an outpatient program. So the idea is that continuity of care that gets you better in each step. So you may start in a very difficult place in the hospital, improve during the sniff stay, and then even improve greater to previous levels of function would be ideal. Through an outpatient or a home therapy program.
So Glen, can you describe some of the changes your company, National Physiatry, has been making with patient care during the last year to adjust to COVID-19?
Sure. It's we've always, physiatrists are quite an interesting group. They're specialists in rehab. So they look at all different types of rehabilitation scenarios. That can be, again, cardiovascular. It can be a slip and fall. It can be a brain injury. It can be stroke scenarios. So as we see this, in addition to that, oftentimes the antibodies are worn down, or their susceptibility to infections rises. So as we saw this, the physiatrists really took an interest back into more infectious disease. We've had to spend a lot of time training and setting up a real protocol for, obviously, for PPE and then for seeing patients and not really transferring within the facility to different locations. So there's been a lot of change. I think vaccinations have come a long way. We have all of our doctors vaccinated, and so the changes were really already there. They just had to be resurrected in terms of infectious disease, as opposed to a broken hip or a knee or something that they're more used to. So it's become a challenge in that.
Cheryl, can you define physiatry for us?
Sure. A physiatrist is a medical specialist. It's a doctor in physical medicine and rehabilitation. So we call them rehab specialists. It is a practice. It is a medical practice, and they work with the rehab teams. We'll talk about the SNF setting. Work with the rehab teams and the physicians, the clinical teams, to help to enhance that patient care that's going to return them to their their previous level of function. They're all about function. Physiatrist, one of our physiatrists said recently, we're all about function. We don't own an organ. So, we look at the whole body, the whole person. They're looking at it psychologically, just all angles to bring that person back to, whole life and get on to what they wanted to do.
So Glenn, I hear there's some sort of COVID therapy. What's done specifically to reduce COVID after symptoms?
Well, it's a great question. I think that we're still feeling around in the dark a little bit about what that looks like. One thing that I know is a fact is the faster that we're able to identify what appears to be, a COVID patient who is improving or is declining, and then identifying whether it could be a longer, more serious issue, as opposed to a shorter issue, which is the 2-week or the 14-day kind of quarantine. And so, from a standpoint of treating post syndromes, it's very, very similar to what physiatrists have always done. They're looking at this as a pain management, psychological management, pain management. And then there are always gait and balance issues. And with COVID, we've really seen an isolation portion that has come into play that it's creating loneliness and that psychological side of it. So oftentimes our doctors will work side by side with psychiatrists or with cardiologists or pulmonologists in order to set that plan and determine what needs to take place next in order to rehabilitate for the best outcomes. That's what physiatrists do. They will reach out to other professionals and other specialties in order to bring them in to supplement what they don't know or what they feel would be more advantageous for recovery.
Glenn, I hear you're spearheading cardiology and pulmonology services into your care, in addition to physiatry. Is this all done through telehealth? And do you think telehealth will be the wave of the future?
I think that, this to take the last one first, I think that telehealth has always been on the brink of having some success. As Cheryl had mentioned, we started out to identify patients that were unable to get the proper help because of location of where they lived or, outlying areas. And we started to put a program together, which was a telephysiatry program. It is not the wave of the future. The future is here, the way that I see it. And we're actually dealing with those things now. A year ago, I would say, yes, in the future, it's going to be more important, but now we've arrived. And really, that's what I see occurring out there as far as telemedicine. But there are some things that are just, you just are unable to diagnose over a line as opposed to, face-to-face meetings and having those kinds of things. So it's going to be a combination. And especially as we reach more vaccinations, there will be a combination of that.
I sat in on a webinar recently with a group of physiatrists who had worked on a report regarding post-COVID clinics last year in Boston and New York. And they had quite a bit of success. These are physiatry-led post-COVID clinics. They had quite a bit of success pulling in other specialties like cardiology, pulmonology, whatever, and established kind of what they called a web of specialists, their go-to specialists, so the go-to cardiologists or pulmonologists. And it's fascinating. Physiatrists are really jazzed about the opportunities they have for the future right now.
Yeah, especially I would assume in a SNF, it's less common to work collaboratively as opposed to like in a hospital where they're all under the same umbrella. So it seems that National Physiatry is putting them all under one umbrella. So are you guys partnering with other companies that provide pulmonologists and cardiologists, or it's all going to be under the National Physiatry company?
I've chosen to partner with a cardiologist that I've known for years, and to really let them do what they do the best. We do physiatry the best. I'm not going to try to conquer pulmonology and cardiology all at the same time. I think that we put people in the right seats and they provide the best services. I think it would be to the detriment for us to try to handle all of them. They do a great job in the cardiology side and the pulmonary side. They don't do a great job in physiatry, but they realize and understand the missing link, which is physiatrists are the missing link. And the pulmonologists and cardiologists know that. They just haven't been able to, really put it together until we've been going through this COVID time period, where they realized how important that they really are to each other. They're very well connected, even though the physiatrist is quite broad in their stroke and in identifying issues. It's great to have a targeted approach as well, especially if it's a heart issue or a respiratory issue, as you can imagine.
Yeah. We're all under the same umbrella of trying to help the patients get better and improve patient care. And because the human body, you know a lot better than I, is all intertwined and connected. So, the more that the specialists are working together, that's the most beneficial. So when did this telehealth piece come in? Was this, you guys were doing this for a while, or this is another offering and you partnered with a telehealth company to bring your physiatry and cardiology and pulmonology services to SNFs?
Well, we definitely work with a team that is a tech team that puts together, the technical side of it, both hardware and software, really, in order to have a smooth introduction into a facility or into a hospital with telehealth. It can be as complicated or as simple as you want it to be. So you want to partner with the people that know the most, again, about what they do. It's all of our proprietary software that we partner with in order to borrow, so to speak. And we pay for that service, but the service is extremely well received. It's very simple to use, and yes, we started about a year before COVID came into our world, and again, we were doing it for outlying areas. There were some of these rural spots that had, it was only one facility in town and had 100 patients and no doctor. And so we started to see them in telehealth, and then we would do once a month or something like that, face-to-face kind of meetings to just make sure that we were diagnosing properly.
So what are some of the challenges using telehealth and telephysiatry, and what are some of the benefits?
Well, the benefits are obvious that we get, they're obvious that we are able to see more patients, and their patients are able to have that additional specialty working with them, even if they live in, the middle of nowhere, or they are in a quarantine situation within the facility. We've done telehealth visits where the doctor is across the hallway and is on a telehealth meeting, with someone who's either infected or is presumed infected, something along those lines. So the challenges are really location, bringing them all together, making sure that people are on time for their appointments, and then dealing with with emergency scenarios where, you know, maybe there is someone who's in quarantine but haven't been diagnosed yet, and then all of a sudden they're diagnosed and they really can't go through a meeting that day. So there's all kinds of variables, I think, that go along with scheduling. You know, it's definitely going to remain a piece of what we do, just like online shopping, just like all of these things that they talk about. So are we going to go back to normal? Well, what does normal look like? Well, normal looks different than it used to look. It's going to be altered. And I really believe that. I think that you're still going to, go to the grocery store as quickly and get in and get out. There's not going to be a lot of shopping. They're ordering from Amazon, baby. That's what they're doing. So, I mean, that's great. I mean, it's fantastic that they can fill a void and they can do that. But it's the same thing in healthcare. I think we're going to see people that really, really are attracted to telehealth, and there are going to be people that prefer face-to-face.
Well, what are the moving parts that need to be dealt with on a daily basis to create the best plan in order to see the best outcomes for your patients?
It's very similar to what it's always been. It's not, there's not a big difference. The primary difference that we bring is that our physiatrists are dedicated to those buildings, and that's where they work. They're full-time, they're employed, they're not running back to their outpatient program down the street. This is a full-time position for them. So they're involved daily. They're involved in the utilization review meetings, which are really reviewing each case, determining whether there needs to be a change of course in the plan or if the plan is working, or recommendations for adjustments to the plan. So we're the biggest benefits are that you've got this dedicated physician who shows up every day and knows all your patients and is there full time.
When patients are released from their skilled nursing facility back into their home, what plan are you creating to create a game-changing recovery for your patients?
Well, there's an ongoing plan. Presumably, you're discharging these patients back to home, wherever home is, at functioning at their original level when they came in. That would be ideal. If there's not, then they're going to discharge them into an outpatient program or a home health program. Home health is not proved to be really successful in therapy. I know that there are therapists that come out and that's, I think, been pretty successful. But as far as physiatrists, doing house calls, I haven't seen that work very well. But there's a community that they're discharging to. So out of the hospital, they're discharging to the physiatrist at the skilled nursing, and then the skilled nursing team is discharging to either an outpatient program or have really given it a stamp of approval that you've reached previous levels of function, and here are some exercise instructions, and if you have issues, reach out and we'll revisit them. But the whole idea is to get them back home functioning like they were before their episode.
One of the things that physiatrists bring to the table here is the ability to talk with the families, which has been really, really important during COVID. It's the education. It's getting everyone on board. Our telehealth tech guys will say, getting people's buy-in, educating people as to what it can do. A lot of that training goes into what makes it successful. And when the physiatrists are improving the communication between the families, but they can talk to the families, and they're improving that communication between the families and therapists and the physicians, whether it's primary, attending, whatever they want to, medical directors, it makes a huge difference. the satisfaction, customer satisfaction is higher, and then the referrals and the census, tend to increase, and that's what we've seen so far.
Cheryl, you've been in the industry for a very long time. What made you decide that you wanted to work with National Physiatry? What attracted you to Glen, Rundell, and that team?
I have been within the industry for a long time. I was adding up the numbers the other night. It's like, wow, it is a long time. And ironically, the skilled area and rehab care was the area that I knew the least about until I met Glen a few years ago. And as COVID came along, I spent a good part of last summer researching. I was fascinated with what was happening and the whole issue of physiatry and where physiatrists could play a part. And so I just kind of became real fascinated with it. And I had been editing Senior Living News and knew Glen, had written about physiatry, but was really excited about it because I think there's such an opportunity. I call it like a new frontier. I don't know. For physiatrists in skilled nursing. COVID brought a lot of things together. It brought, telehealth together with the physiatrists. Physiatrists were mostly in the hospitals. And now, they're using, they're in the SNF setting with telehealth. And I think there's just a huge opportunity, and opportunity excites me anytime. So I'm excited because they're excited.
Cheryl, where do you see National Physiatry, you adding to that team? Where do you see National Physiatry coming in a year, 2 years, 5 years down the line?
Oh boy, I have no idea, but I think education and communication, a lot of it goes back to education and communication. We have a huge job to just educate people, like Glen said, let people know what physiatry is, because I never heard the word before I met Glen several years ago. Never heard the word. I've talked to people in rehab that didn't know what it was. They said, I worked in rehab. Well, they never had a physiatrist. So, I think education is a lot of it, and continuing to communicate and then just get the word out. I mean, my background honestly is in public relations. So, I get really excited about the opportunity to just tell more people about the benefits. And, really what made me want to do this in this area was skilled nursing, was hit really hard with COVID, and the opportunity to potentially help so many of those people, as well as physiatry as a profession, just, that kind of just rang my bell.
So Glen, Cheryl, thank you so much for coming on and joining us on the SNF Spotlight series. I'm your host, Yitz Rubin, and thank you so much for watching the SNF Spotlight series. We are here giving you an inside look of things that are going on in the long-term elderly care space. Thank you for sharing this tremendously important part of senior care. The SNF Spotlight series highlights healthcare heroes and thought leaders in the skilled nursing community. We're building awareness, trust, and shining the light on SNFs. So stay tuned. Remember to like, comment, and share.